All right. Good evening, everybody. Sorry for the slightly delayed start. We had a technical glitch there. Namely, I got disconnected from the call. So with hope, we are ready to go. And with that, since we're getting a little bit of a late start, let's dive right in and welcome you to this installment of the Practice Perfection web-based education series. I am Danny Bobrow, President of AIM Dental Marketing. And before we get to today's very special tag team presentation, let's all sigh a collective sigh of relief here, take a deep breath, and let me remind you that Practice Perfection webcasts run for around 90 minutes. I invite you at any time to submit your questions or comments using the question button on your screen. We will do our best to get to all your questions, to have them all answered, if not during the webcast, then shortly thereafter. As an attendee at today's webcast, you will be offered the opportunity to receive 1.5 hours of CE credit. Shortly following the webcast, you will be emailed a brief survey. You will have 30 days to complete and return this survey to us, and you'll then receive your CE certificate. I'm joined this evening by Virginia Norton, who will field your questions during the talk. Today's presentation, Saving Lives by Improving Sleep, is delivered by Drs. Kelly Olson and Barry Raphael. Dr. Barry Raphael has been in private practice in orthodontics since 1983. Still there? Yep. I'm sorry about that. Since 1983, carrying on a family tradition that began in 1950. His interest in early treatment has led to the incorporation of techniques designed to prevent malocclusion and airway-related oral dysfunctions, or the other AROD, such as sleep-disordered breathing and harmful oral habits. Dr. Raphael teaches these techniques on both the graduate and postgraduate levels. He is founder of the new Raphael Center for Integrative Education, whose mission is to teach patients, parents, and professionals about ARODs and treatment alternatives. Dr. Kelly Olson's background as a neuropharmacologist began with a master's in science from the University of North Dakota. She received her Ph.D. from the University of Manitoba, Winnipeg, in pharmacology and therapeutics. She was director of research and development for a Wisconsin-based biotech company, where she led a team of scientists toward a better understanding of how the nervous, endocrine, and immune systems work together in both sickness and health. She currently works as Clinical Research and Development Director at SleepImage in Denver, Colorado, developing patents, examining molecular aspects of sleep neural circuitry, investigating clinical data, presenting to the medical community, and coordinating global research for a sleep monitoring medical device. I first became aware of their technique for objectively and reliably measuring sleep quality at the American Academy of Private Physicians meeting this past October, and knew we had to get them on the program. And we're certainly grateful that they did agree to do so. I especially wish to thank and acknowledge Kelly, who is joining us today from clear across the globe in Australia. And with that, it is my sincere pleasure to introduce Drs. Barry Raphael and Kelly Olson. Kelly will speak first, followed by Barry. Kelly?
Great, thank you, Danny, and thanks for the introduction. Thanks for the opportunity to speak, and welcome everyone. I'm just going to bring up my presentation for everyone to see. Great, okay, I think we're good. And Danny, as long as everyone can see the presentation, we're ready to go here. Again, like I said, thank you to everyone for taking the time out of their day to listen to Dr. Raphael and I speak, specifically on cardiopulmonary coupling and sleep pathology. I'll describe a little bit about cardiopulmonary coupling at the beginning. Dr. Raphael will also talk about CPC, as we call it, and we'll draw all conclusions back to sleep pathology and show you how you can use cardiopulmonary coupling to help with understanding sleep pathology in your patients. So we'll get started. I've listed here cardiopulmonary coupling as my very first slide. I'll do a 30,000-foot overview of what cardiopulmonary coupling is, and then we'll get into it in terms of its clinical relevance as we move through the presentations. So to begin, cardiopulmonary coupling, or CPC, as I mentioned, is really based on two biorhythms. The first one being heart rate variability. And when we talk about heart rate variability, heart rate variability has been studied for a number of years now, and it's really looking at the difference between, or the variability, if you will, between the R peaks in a ECG, or heart rate variability, as it's aptly called. The interesting piece to heart rate variability is it's a really simple view into autonomic function in the body. So specifically looking at sympathetic system and the parasympathetic system. Now we know, not to get into heavy biochemistry here, but we know that when a patient sleeps, when we all sleep, our parasympathetic system really takes over. So that sort of rest and digest, if you will, mode in which the body gets into at night really is it's the producer of sleep. It allows us to sleep well. Now, the sympathetic system is more of that fight or flight. That's when we need energy. We need to be on top of our game, and we need to be alert. And as you know, for proper sleep health, we really want that parasympathetic dominance. So heart rate variability is just that. It's looking at the variation in between the R peaks, which every single heartbeat has. Now, the respiratory rate is the second biorhythm that we were talking about, or that I had mentioned. And this respiratory rate is derived from the ECG. So we call it EDR. The literature calls it EDR. And essentially what that is looking at the respiratory rate based on the changes in heart rate. And so really what it is it reflects the amplitude of the QRS complex, which we just talked about in terms of a heartbeat, that results in shifts from the cardiac electrical axis. And it's relative to the electrodes that are on a patient's chest, and of course also changes in that thoracic impedance as the lungs fill and empty. So we've got two main biorhythms that CPC measures, and that is heart rate variability and of course ECG-derived respiration. Now, the synchronicity between these two biorhythms really represents stable non-REM sleep. And so that's really important. The more in sync the heart rate and the breathing rate is, the better the patient's chance of having stable sleep. Now I say chance. We know that the synchronicity between these two biorhythms really is indicative of that stable non-REM sleep. It's very important to obtain that while sleeping. Now the more asynchronous function between heart rate and the respiratory rate really is indicative of unstable non-REM sleep, also wake and REM. And I'll show you through the presentation, and Dr. Raphael will also get into it when he gets into the case studies, how we can determine REM. So we can look at things like stable non-REM sleep, unstable non-REM sleep, wake, and REM by using CPC. Just a little bit more information about heart rate variability and the autonomic nervous system activity that I mentioned previously. Heart rate variability has really been around since the study of heart rate variability has really been around since 1965. That's when that clinical relevance was first noted, and people started using it. Physicians, clinicians started using heart rate variability in their practices, looking at autonomic tone. As I mentioned, it measures the variation between the R peaks, and of course that's just between heartbeats. It's often used as an estimate of autonomic nervous system activity. So again, when I talked about that sympathetic and parasympathetic, it's more like an oscillation. One is never off while the other is solely on. So it's an oscillation between those two branches of the autonomic nervous system. A depressed or impaired or aberrant heart rate variability most certainly can predict the risk of various pathologies. such things as sleep issues, of course, which we'll touch on today, as well as things as like diabetic neuropathies and also myocardial issues as well. And so heart rate variability really has a strong correlation with opening a window into pathology. Again, we talked about the ECG-derived respiration being the second parameter that CPC examines. Getting a little bit deeper into what ECG or EDR is it, again, as I mentioned, it's based on the positions of those electrodes on the chest surface. And so they move relative to the heart, and thoracic impedance varies as the lungs fill and empty. So think of it as that kind of, that sort of mechanistic viewpoint of breathing and how it pertains to that movement of the heart in the transthoracic cavity. So it's very, very physiological, very objective way to measure how the heart is beating, the health of the heart, as well as the health of the respiratory response or respiratory issues, if you will, if pathology is present. Now, the physical expansion and contraction of the chest absolutely results in the amplitude variations in the ECG trace, and CPC will pick those changes up or those variations up and report that out. And so as we look at a patient's health and pathology, so we've got health and we've also got a disease state, we can look at the changes in those physical parameters, whether it be heart rate or breathing rate, and we can determine pathology from those parameters. Now, of course, the patient history and medication use and various other pieces to the puzzle, if you will, are also very important. But this is the main premise of CPC. So as we move forward, you have that foundational understanding of what CPC is. And this is just another slide describing EDR. Mean heart signals will display variations in respiration. We know that already. And then changes in autonomic tone, again, those branches between that sympathetic and parasympathetic functioning, will also accompany normal respiration. And so we know that as a patient sleeps, as we sleep, we know that the heart rate decreases. We know that breathing will also decrease somewhat. In REM, it's a different story. But we can see those variations throughout the night. And I've listed here as an example, apnea may be associated with tachycardia. Of course, we know that when someone holds their breath, there's a very good potential of having that heart rate increase. And so CPC can identify that, and when the report is shown, you can see that on the report itself. And so, by report, it's what we'll be talking about, Dr. Raphael and I, when we discuss our case studies. So you'll see that in action, but for now, this is the foundational background between those two signals. So what are some of the advantages of the combined detection of the two? Well, let's have a look at that. So the simultaneous examination of both the heart rate variability and EDR provides valuable information regarding tone, or autonomic tone, as we talked about. But in addition, the changes in respiration due to such things, so such pathology as apnea or upper airway resistance. It has a distinct clinical advantage over apnea testers. And I say that because many times sleep pathology may have a foot in apnea, but most certainly there are other pieces to sleep pathology. And so having a look at the combined use of HRV and EDR, we can look even deeper than apnea. So apnea is important, but we can go one step further to look at sleep quality and sleep pathology on a deeper level. And we'll talk about this as we go through our clinical studies, or our clinical case studies. In addition to detecting sleep-disordered breathing, which we've been talking a little bit about, it provides information on central sleep apnea, the effects of stress, and the presence of limb movements, just to name a few. And I think this will be really important in your clinics as we move forward. Many of you know that if you have a patient who may present with symptoms such as central sleep apnea, where we know that that's a central function, not a mechanistic or a closing of the throat, Many of you may or may not know this, but if you send your patient to an overnight study and a CPAP is suggested or given to the patient, they'll respond very adversely to that type of modality if they have a central sleep apnea. So imagine if you can determine that beforehand, before you potentially send your patient to an overnight polysomnography or even a home apnea test or home sleep test. Imagine if you can be able to determine that a priori or beforehand, knowing that you would minimize that discomfort for your patient. Well, CPC can do that for you. And so again, as we move forward, we'll have a look at that at close to the end of my presentation, what central sleep apnea looks like. And so again, I keep reiterating this, but CPC can get you that much further into your patient's sleep pathology. Let's see, I'm just trying to advance the slide here. There we go. Good. So this is a picture of sleep. And this is important to show you just to get your mind around what you're looking at in terms of a CPC spectrogram. This picture you see in front of you with the white peaks and the gray peaks at the bottom, this is what's called a spectrogram. So anytime a CPC test is given, you will be given this type of information. Now it looks a little bit nondescript right now and perhaps maybe even a little bit impending or scary to look at, if you will, but I'll break it down really quickly and really simply. This is a really good picture of what stable sleep looks like. I'll draw your attention to the white peaks in particular. What you're looking at here are high amplitude. On the y-axis, you'll see the value in hertz, so that gives you your information about amplitude. But you're also looking at those wide, instead of the narrow peaks, but more of the wide peaks over the process of the night. So on the x-axis, if you imagine this, that's time. So the y-axis is hertz, and the x-axis is time. And so what you want to see with your patient for a stable sleeper is a predominance of those white peaks. Now, they're measured as high frequency or high frequency coupling, but that's indicative of stable non-REM sleep. So anytime you see a constellation such as this, where you've got a predominance in high frequency coupling, you know that your patient is experiencing good sessions of stable sleep, and that's what you want to see. This is representative of someone who has a healthy sleep. Now on the opposite end of the spectrum, this this is representative of someone that has poor sleep. And in particular, not to put a name to this, but this would happen to be my dad's sleep. Unfortunately, he has a really hard time with snoring, etc. But this is representative of a very, very poor sleeper, now unstable sleep. So as you can see, in comparison to the slide beforehand, and we see that here, there's a predominance of that stable non-REM sleep in that high frequency domain, those white peaks. Now have a look at this spectrogram and you can see the difference. So this is not difficult to discern whether or not your patient has good or poor sleep. This most certainly is unstable sleep. So again, this person, being my dad, needs assistance with sleep. So again, stark contrast between stable and unstable. So I just want to describe briefly what SleepImage is. Now, we talked about cardiopulmonary coupling, and Danny had mentioned that I am the Director of Research and Development at SleepImage. I just wanted to give you a quick overview of the device that uses CPC to capture sleep quality. And as you can see at the top on the right, that's a picture of what the setup is for this medical device. Now, it is FDA cleared as a medical device. There are a number of patents on the technology. Specifically, it identifies CPC, so we're looking at heart rate variability as well as that EDR. But in addition to that, there's a 3D accelerometer within the device itself that very expertly picks up and sensitively picks up actigraphy, snore events, as well as body position. And in addition to this modality, there's also an option to use a pulse oximeter that can be synced up in terms of time, looking at both oxygen desaturations as well as everything else that I described that the SleepImage recorder will also record. So that's an option, being able to look at oxygen desaturations. And I think that's something that is important, especially in looking at sleep pathology. As you move forward and use the testing as a baseline for your patient, you apply your particular therapy for upper airway resistance, OSA, etc. You can then use this technology to monitor your therapeutic efficacy. So we'll get into that a little bit more, but I wanted to describe to you the options and what you can measure with the SleepImage recorder and the optional oximetry. As I talked about previously, this recorder will help identify, based on the report that's delivered from the information recorded, will help you identify stable versus unstable non-REM sleep. Now, the really interesting thing as well about this is, as you can see in that picture on the top right, very, very simple to attach to your patient. So putting it on children all the way up to a geriatric population is very, very simple. Children, oftentimes, you set it up in such a way, you put a t-shirt on them, and they forget that it's even on them. And so at night, you're able to detect their sleep quality without them even knowing. And there's a story that, that we know where a person wore the device overseas. So they had it on them while they were on the plane. And of course, we sleep when we're on the plane, etc. But it wasn't until the person was in the taxi cab that they sort of reached up to scratch their collarbone, and they realized that they had the SleepImage device still on them. So it is very non-invasive. It does a lot of work for you without you knowing that it's there. And another story, quick story, is on the geriatric population, geriatric patients, those that have issues with technology, etc., or perhaps some sort of cognitive impairments of some kind, will find that the use of this device very simple. As I said, very non-invasive and light. It weighs less than an ounce, so very, very convenient. Identifies sleep dysfunction with a single number. So that single number, which we'll talk about in a few minutes, was what's called sleep quality index. And that's simply good, stable sleep over poor, unstable sleep. So it gives you a number with which to start with. I like to call it a stepping off point or an indicator point. So you obtain that SQI, and then from there you can use that number again to look at therapeutic efficacy as you move forward. Tracking sleep health over time for optimal and beneficial therapy intervention. We talked about that in terms of therapeutic efficacy. Identifies obstructive, central, and complex sleep apnea. We touched on that a little bit as well when I was talking to you about being able to determine the differences between these three forms of apnea. And then, of course, minimal patient setup, and you can see that in the picture. One of the other really interesting points is there's no buttons to press. So it's very sensitive to picking up heart rate, and once it picks up a heart rate, it starts automatically. Data collection, this is what you'll see when a report is created. Sleep quality, of course, being in that spectrogram like we talked about previously when I showed you good versus poor sleep. Directly below that, directly below the gray peaks, you'll see lines that go across on the x-axis. That's your body position or your patient's body position. Again, based on 3D accelerometer technology, you're able to discern if your patient is up, if they're left, prone, right, supine. Really interesting to have this information, because if you have a patient with positional upper airway resistance of some kind, positional OSA, you'll be able to see that. You'll be able to determine, is my patient on their back the entire night? Do they snore only on their back? You know, what's going on? Below that directly is actigraphy. That is limb movement specifically. So you're looking at the vertical inflections as being limb movements, and you can see that across the span of the night. And then finally, snore events. Now those blue lines that you see there, tiny blue lines, indicate snore events. So every time a person takes in a breath and they snore, you can see that. So as we move forward, I'll show you how we can correlate all of those parameters into determining the pathology of your patient. these are the SleepImage Benefits. I won't go through these in detail. We're already nearly 30 minutes into the presentation, and I really want to get to the case studies. So I'll leave this on. I'll leave this to you to have a look at. But what we've done is we've broken down, pardon me, the benefits to the patient as well as to the clinician of using the CPC or the sleep image system. And so a lot of those things are listed there. Now this is not an exhaustive list, but it gives you an idea of the benefits of using CPC with your patients. We've covered most of these. This is just a good summary slide. All right, so let's look at a case study example using CPC. So this is in front of you what you would see in a typical report from a sleep image test. So using CPC, you would check it out to the patient, check the device out to the patient, have them wear it for a night or two. 1 night is sufficient. Of course, 2 or 3 nights, it gives you a broader view of what's going on with your patient. But this does give you, on the left-hand side of your screen, a really good visual representation of what you will see with a report. So this is representative of a 21-year-old male. This person is 6'2", 240 pounds. He has a BMI of 30. And when he did an overnight polysomnography test, it was discovered that he had an apnea-hypopnea index of 69. So there was definitely some respiratory issues there. And his baseline sleep image test, the SQI was set at 0.60. And so if you look at the top of the slide, just to the left, you'll see it's kind of a Christmas tree colored bar, red on the left and green on the right. And you'll also see a fairly thick arrow just hovering above that, the red side. So what this is a visual indication of that sleep quality number, 0.60. And we can see at a moment's glance where that arrow is, indicating that this patient is experiencing overall poor quality sleep. Now, in the middle of that Christmas tree bar, or that green and red bar, is an area that's somewhat gray. And I'm not sure if you can see it all that well. Hopefully you can tell the differences between the colors. But in the middle of this particular bar is an arbitrary cutoff. We use that sort of to the left of that is bad sleep, to the right of that is good sleep. But the point is that unless you've got a patient who is well off to the right, well into good sleep, and you can actually correlate that with those white peaks of high frequency or stable non-REM sleep, there's always room for improvement. So what you see in front of you right now is a 21-year-old male who appears to have, in this particular test, poor sleep, so poor sleep quality, and obvious room for improvement. And so as we move through the rest of the parameters, let's have a look at what else is going on. So we definitely see prevalent snoring and actigraphy. And how do we see that? Well, if you recall from the previous slide, at the very, very bottom of this slide, you'll see vertical inflections and ACT on the y-axis as the sort of the label for this particular line. So those black vertical lines all the way across the x-axis is indicative of limb movements of some kind. So we see in this particular patient, we see clusters of those limb movements. Now, when we mentioned that snoring was also prevalent, just below that, you'll see blue lines across that x-axis. That's indicating as we look at this, that's an indication that there are many snore events going on as well. But of interest, I really want to draw your attention to, let's look at that body position. As you recall, that was directly under the spectrogram in previous pictures or previous slides. Now above that, in between that, or just underneath the gray peaks there, you'll see SaO2 or SpO2 percent on the y-axis. So that's where we have that oxygen desaturation information that we talked about previously. That was an option. But in this case, this patient had this done. And so you can have a look at what oxygen desaturations will present as. And what you'll find is, and we can look at about a third of the way through this study from the left-hand side, you can see that there are some clear oxygen desaturations going on. The really interesting piece here is that's very correlated with low-frequency coupling or unstable sleep. It makes sense. When you have desats and oxygen, you can definitely see, and maybe you can see it better with my cursor here, you can see this section of oxygen desaturation. But look at this. Look at the predominance of this low-frequency coupling here. Very, very correlated. But also of interest, let's look down here. And this is, again, our body positional changes. This patient is supine. So they're supine. They've got desaturations. They've got very, very dominant, unstable non-REM sleep. And as we look down, we can see also correlated with actigraphy and snore predominance. And so just to the left of that, when the patient is on their left side, look what happens. Desaturations go away. We've got a predominance of high-frequency coupling or stable non-REM sleep. We've got very little to no actigraphy and no snoring. So isn't that interesting how you can see, and also valuable clinically, that by using this body positional as sort of your axis, we can look at, is there stable sleep or unstable sleep? Is it due to things such as desaturations? Is it due to actigraphy? Is it due to snore events? Or is there a combination thereof? And so when looking at a report such as this, we can confidently say that absolutely snoring, actigraphy, and desaturations are most certainly contributing to this person's poor quality of sleep. But not only that, while he's supine, most of these pathologies are really, really evident. And so perhaps this patient would do very well to begin with something very simple, such as a promotion of non-supine sleep. So again, that's something very simple that we can start with, but we also note that there's major sessions here of fragmented sleep. And so if you recall back to that stable non-REM sleep slide near the beginning of this presentation, you recall that the amplitude of those white peaks as well as the width of those peaks was really reflexive of good, stable, restorative sleep. But we look at this particular patient, and he has a really hard time. His body's having a very difficult time getting into stable non-REM. And so we can look at why that is by looking at these other parameters. Well, let's look now at his follow-up study. And this is the retest after oral appliance therapy. And so again, drawing your attention to the top, you can now see where this moved, the large arrow has moved into that sort of midpoint. Again, looking at sleep quality, he went from a 0.6 to a 1.83. So there is significant improvement in this particular patient with the application of that oral appliance. His home sleep test at this point, or a home apnea tester, indicated an AHI of 3, so absolutely much better than the 69 that he had at the beginning. So the oral appliance is obviously doing its job. The snore is all but eliminated, and so let's see if we can, not sure if we can scoot down there to see that. It's a little bit tougher to see. Yes, okay. There we go. We can see that on this left-hand side, the snore. Remember in the slide previous, well, instead of remember, how about I just show you? In the slide previous to this, we can see that the snoring was very, very dramatic throughout the entire study. There was a little bit of reprieve at times, but fairly dramatic. We'll look at it now. There's just a few little indications of snore throughout the night, very, very minimal, and most of them are associated with the actigraphy anyways. We also notice that there's less actigraphy, so as we talk about those limb movements, that oral appliance has also assisted with decreasing limb movements. And we know that when a patient is snoring or gasping or experiencing obstructive sleep apnea, there's no question that it's decreasing the oxygen that's flowing through the body, flowing through the blood in particular. And so even if we only looked at that and we see that it's remedied those limb movements, that's a benefit to this particular patient, because without those limb movements, this is a perfect example here on the left-hand side, without those limb movements, look what's happening to his high-frequency coupling, or that stable non-REM sleep. Very, very present. So when we decrease the limb movements with this particular patient, we also instituted an increase in that stable non-REM sleep. We find that there's more consolidated stable sleep, which of course physiologically is of distinct benefit to the patient. More consolidated sleep helps to eliminate things such as excessive daytime sleepiness. It helps with focus and cognitive function, etc. And so overall, this oral appliance with this particular patient did the job well. And you can see here, just as a side note, look what happened to his oxygen capacity or oxygen carrying capacity. We're looking at SpO2 here. There are very little, very, very few and minor DSATs. So the oral appliance has done this particular patient very well. So just sort of overall conclusions, very simply, and we most certainly can get much more in depth, but this is a simple overview of those particular conclusions as they relate to the study. We saw very much an improvement in sleep quality, greater incidence of stable non-REM sleep, although I've put in this particular slide that there's room for improvement. The snore events were all but abolished, much less actigraphy, so very few clustering of limb movements. Oxygen desaturations were nearly eliminated, and again we saw that visually. I'm very much a visual learner, so when I see this, I take great comfort in knowing that my particular therapeutic choice, an OA in this instance, most definitely assisted this patient with proper sleep control. So 2 more slides before I hand the presentation over to Dr. Raphael. I just wanted to have to point out, we talked about obstructive sleep apnea and central sleep apnea, and of course the complex version or the mix of the two. I wanted to show you what that looks like. And so this is a 72-year-old male, 6 foot in height, 190 pounds, a BMI of 22, and no particular additional diagnostic test results before taking a CPC test. Hit an SQI of 0.22. Now, in your experience, just in the little bit of time that we've spent on this, you can see that that arrow is far to the left during that poor quality sleep. In addition to that, you can also see that this patient is fairly devoid of stable non-REM sleep. Look at the dominance of these gray peaks, or that unstable non-REM sleep. This particular patient also had complaints of daytime somnolence. He most certainly has clusters of actigraphy throughout the night and very little stable sleep, as I mentioned. Now, we didn't look at this beforehand in the previous study because it wasn't prevalent to that study, but in this patient study, this is a separate view that you can look at on a sleep image report. And what that does, or what this provides to you, is a look specifically at low frequency coupling, or that unstable non-REM sleep. We now have time on the y-axis and frequency on the x-axis, thus the 90-degree view title. But the red peaks can indicate a periodic type of breathing that's associated with such things as central sleep apnea. And so when you see or have a patient that has this distinct lineup of red peaks, very, very regimented, it indicates a rhythmic function in the system. And many times it's a rhythmic breathing or a cessation of breathing, very, very reminiscent of Shen-Stokes breathing. And of course that's a hallmark of central sleep apnea. So when you see something like this in a patient, you can definitely be sure that it's a rhythmic response in the system. And so giving this type of information, if you choose to send your patient to an overnight polysomnography, giving this information to the sleep physician to then talk to the technician about will absolutely decrease your patient's discomfort as they move through a polysomnography test. Now that doesn't take into consideration, of course, all the electrodes that they'll be hooked up to, but when you look at the fact that this particular patient likely has central sleep apnea, having something like this or arming the technician with this kind of information will decrease the discomfort that your patient will have to experience. It's evident that the patient will not benefit from an oral appliance. Something else will definitely be needed to take its place, so that also helps you as the dentist to be able to say, you know what, we need to bring in further assistance to help you. And so you're not losing or potentially losing a patient by giving them something that they may not necessarily need. You can now expertly maneuver them through the therapeutic process to help them have a modality that will assist them with their breathing. And of course, the SpO2 would likely indicate desaturations, but you'd have no indication as to why. Whereas now you've got an indication. You've got sort of a map, if you will, to help your patient. Clinical relevancy, not going to go through this in great detail. I really would like to pass the baton over to Dr. Raphael, but I'll touch on these very briefly. Healthy sleep is integral to achieving and maintaining positive clinical outcomes. We know that as a fact, and most certainly to manage disease risk. Sleep measurements can guide therapeutic selections. Absolutely important as your patient is going through their therapeutic journey toward health. Improves treatment effectiveness and patient outcomes. I think it's really important to highlight here, thus improving patient retention. That's really important. You don't want to lose your patient. You obviously want to help them. Sleep quality has been difficult to assess until now. And again, sleep quality being the operative two words here, very difficult to assess until CPC. And of course, SleepImage will differentiate your clinical offerings. So the depth of sleep health and subsequent care from many other dental practices out there. So this gives you an advantage by not only helping you look at at sleep pathology, but arming you with information that many other dental practices won't have. Becoming a standard of care, again, this is something that you can have a look at your leisure, but essentially what the highlights of this particular slide is being able to screen all patients for sleep issues using the SleepImage system. And we stress here that this is of low cost. And so your patient healthcare right now is, the patients are spending money, especially to have labs done, etc. We know that looking at sleep quality is incredibly important as an overall view of health. Very, very important. And so using the SleepImage system with its low cost is an absolute coup for patients as well. Identifying upper airway resistance, of course we talked about that. Assisting you with fitting the oral appliance, helping you with titration issues, using the SleepImage device to measure the efficacy over time. Very, very simple to do to help you with your oral appliance titration with your patient. You can get very, very specific with the SleepImage device. Reviewing the SleepImage results with the patient, again, as we mentioned, adjusting the oral appliance if necessary. Very quick, very simple, and very effective. Ensure positive results over 90 days or positive diagnosis. And then, of course, follow-up using the SleepImage test every 6 to 12 months. So after the titration has been perfected or polished, every 6 to 12 months using the SleepImage device to measure sleep quality over time is really an effective way to monitor and to make accurate more of those patient outcomes. You can adjust the therapy, you can assist your patient very, very quickly and easily. So with that, I thank you for your attention. We went through a few of the slides fairly quickly, but I thank you for your attention. And I'm going to turn over the presentation now to Dr. Raphael. And I'm going to, I'll also be standing by. So as questions come in, we'll be here. But Dr. Raphael, I'm going to send this over to you.
And while you're doing that, Kelly, let me first of all thank you very much for a great presentation, very enlightening. And I love how this paints the picture for the patient and talk about engaging and empowering the patient in their own care, what a wonderful tool to do that. A reason to meet with them and to explain things in terms that they can understand. I think it's a wonderful tool for retention, and not only that, but for referral, because people can talk about this and they'll be excited about it, and the results are going to be as clear as can be. And you know, if anyone does have concerns about having missed anything, one thing I missed or neglected to remind everybody is that this webcast is being recorded. So I hope you'll just relax and enjoy it, and if you felt you missed anything, just rest easy in the knowledge that you'll be receiving that. And that's one less reason to lose any sleep tonight, so that's appropriate. And with that, Dr. Raphael, please, I'll hand it over to you. Thanks again, Kelly.
Well, hello, everybody. I know I have lots of friends out there. It's good to virtually see you tonight, and thanks for coming to join us. Kelly, that was a great presentation. I think I learned some new things tonight, too. I have a question for you before I get started. You know, when you get the results back, sometimes people almost can't believe that the results that they see are true to them, because they almost have no idea how well they sleep, and they want to do it over again.
That's right.
Is it necessary to repeat a study once you get a result?
Well, and I just briefly, good question, I just briefly touched on that. And knowing that one night is sufficient to, especially getting a baseline, but having more than one night is certainly of benefit. You may not necessarily have that luxury with your patients. They may just be amenable to giving you one night, but most certainly if you can have two or more, it's definitely to your advantage as a dentist, as a clinician, to look over time to see your patients trending. So yes, having a repeat study after that first one, before your therapeutic intervention, that's absolutely fine, and it does give you a little bit of a broader view into your patient's health.
Thank you. So, I have lots of questions about this because basically I'm a beginner, and though I think I have an interesting story to tell, I realize that I am very much a novice at this, and I don't do sleep dentistry. As an orthodontist, and I've been an orthodontist for 30 years, it's only been recently that I thought that a modality like this would have any usefulness to me. And when they asked me, when SleepImage asked me to participate in this, I really jumped at the chance, thinking that I want other people to see what I've been seeing recently. But I also know that this modality really has made things very easy for me, because I don't have a lot of background in sleep medicine or dental sleep medicine. And I think there are some of you out there in the audience I know that are fluent in this. We would love to hear from you in the future too. So let me go ahead and start my presentation, which is about connecting the dots between a low SQI, poor and unstable sleep, and crooked teeth. And it seems like that would be quite a long chasm to traverse. But I'm going to put together the story of how I've come to look at things in my orthodontic career that I think will make this connection for you, and then just give you one idea of how the SleepImage modality can be useful to you in your practice. So, as an orthodontist, I really, for the first 25 years of my practice, I really had no idea that there was a connection. In the past 5 or 6 years, I've been led on an intellectual, philosophical, and practical journey to change the way I practice orthodontics. And I freely admit that 5, 6 years ago, I didn't even know what sleep apnea was, and never thought I would really need to know about it. But now I do. And for those of you who are also a novice like I was, this is the simple explanation that when we're lying down at night, we need to be able to breathe freely through our nose, have the air go through the back of our throat and into our lungs without obstruction. And when the space between the soft tissues gets close enough, the way the air flows through can make the tissues vibrate. That rattling sound is what snoring is. Now they get closer together, and it actually becomes a little difficult to breathe, where our bodies have to make some amount of effort to draw the air through this narrow tube. And then finally, sometimes the tube will close up enough that the sleeping brain has to arouse itself and arouse the body in order to start breathing again. Now, it's estimated that true sleep apnea, is prevalent in a minority of the population, but upper airway resistance is thought to be prevalent in a large number of the population. Now, my interest in this really is not just with adults, but especially with children. And we know that when children are small, their airways are shaped differently than adults. And in some ways, they are more subject to airway resistance problems from the moment of birth. If their palates have not shaped well, or if lymph tissue is swollen, it can make it very difficult for a child to breathe. And we've linked instances of sudden infant death syndrome to this inability to breathe well. But there's a bigger picture going on here, and this picture has to do with not just dentistry, but medicine and the study of evolutionary medicine, which is probably only about 20, 30 years old, is talking about how the human body, though it has survived for millions of years in its present form for maybe 200,000 years, has been rapidly changing over the last 50 or 60. My friend Kevin Boyd, who's a pedodontist in Chicago, is doing his master's on Darwinian dentistry, showing how the mismatch between our current environment, which includes the things we do, the things we eat, and the way we feel about things, is kind of a mismatch with the way our genetics has been prepared to encounter them. And so the presence of a large number of chronic non-communicable diseases has been increasing in intensity, frequency, and onset, so that obesity is something we're seeing in very young children now. Type 2 diabetes is no longer adult onset diabetes. And among these chronic non-communicable diseases, I also include caries, malocclusion, and sleep apnea. And we are also seeing these happen in younger and younger children. So this is what the anthropologists show us about the modern face. The images at the bottom, particularly the skull that's on the bottom left, show what the anthropologists see in skulls before, say, 300, 400, 500 years ago. And some of you dentists may occasionally see arches like this, but certainly as an orthodontist, I never see anybody like this. And please note that there are third molars present in those arches. Plenty of room for the teeth, big, broad arches, a wide, flat palate, which, of course, is not only the roof of the mouth, but the floor of the nose. And you can see the nasal apertures as quite wide there, too. In flesh and blood, that translates to the picture on the lower right with a big, broad, beautiful arch and so forth. Well, the pictures up on top, especially the one on the upper right, while that may be a terrible case, It is certainly not strange for me to see such cases in an orthodontic office today. And its corollary on the upper left shows that not only the palate being narrow, but the nasal apertures being narrow as well. So what is this? What's happening to the modern face that children should be walking around looking like this? When we look at the pattern of growth, and you can see these slides playing, on the right and the left. The one on the right represents what we would consider normal. I take that back. Ideal growth. I take normal back because not many people are growing like this anymore, where the maxilla grows downward and forward in the face, where the front of the face is full, and hence there's plenty of room for the tongue behind the teeth, and also a much larger nasal airway, and frankly a wider pharyngeal airway. More commonly, the image on the left is showing a maxilla that has drooped downward, with the upper front teeth falling down and backward, often with the lower jaw being hindered in its forward growth as well. The way this happens is related to posture, and the particular posture that's directly involved here has to do with the way the tongue sits on the palate. The tongue being the support or scaffold around which the upper jaw forms. So when the mouth is closed, the palate forms in that nice broad forward arch form. When the mouth hangs open for any reason, then that maxilla can change shape. And the typical outcome of this postural problem and this modern form of face is what I call bi-maxillary retrusion. By bi-maxillary, I mean both jaws. And frankly, this is a condition that's not readily acknowledged in the orthodontic literature. In that, for instance, when upper teeth are sticking way out over the lower teeth, it's often assumed that either the upper front teeth are too far forward or the lower is too far back. My contention is that actually both jaws and both sets of teeth are too far back in the face, as you can see here, no matter what the arrangement of the front teeth is with each other. This picture shows a face that's compared to tracing from the Bolton standards, a collection of normal children with straight teeth over a period of many, many years. So what you see there is what would typically be thought of as an average, an average face of in this case, a 14-year-old boy. But the truth is, in practice, I never see anybody in front of that line, and I frequently see people behind that line. So every day in my practice, these are the profiles that I see. And if it's not familiar to you, the more you look at this, the more you'll see it in faces, of children and adults. And I'm not too proud to say that many of the cases, the pictures that you see here, are my post-treatment results. In other words, for the 25 years that I was interested in producing straight teeth, I didn't really look at this kind of profile as much. Now, when I see a result with beautiful straight teeth and a face like this, I still consider it, I now consider it a failure, because I realize there's something more to it. And what's more to it is that the faces that have poorly developed jaws, where both the upper and lower jaw have failed to grow forward, that the nasopharyngeal airway is smaller. And when the jaws grow fully and grow horizontally forward and full and wide, and there's plenty of room for the tongue in the front of the face, that the nasopharyngeal airway is larger. And the significance of this isn't hard to understand. Studies are showing, though, that while we think that sleep apnea is usually a disease of older fat men, that obesity is not really the only factor that's involved. In fact, the shape of the face is just as relevant to how well a person breathes as is obesity. And to make sense of it, the smaller the airway starts with, certainly the less it's going to take to clog it up with even a mild amount of weight gain or age or tissue inflammation. And there are a number of studies that are showing just how important facial shape is to good sleep. In this particular study, it actually did not show that obesity was relevant at all in young children. Tonsils and adenoids being swollen, of course, is relevant, and it is something we need to look at. Fortunately, the pediatricians are now considering tonsil and adenectomy a first line of defense against sleep-disordered breathing in children. Of course, I think there are plenty of ways to help shrink adenoid tissue before you have to cut it out, but that's another story. But also look at crossbite, which is usually an indication of maxillary narrowness, and facial convexity, which is usually an indication of lower jaw retrusion, and see how they are just as powerful factors in sleep-disordered breathing as swollen tonsils and adenoids. Christian Guilleminault has long been considered one of the godfathers of sleep medicine, in that he first defined obstructive sleep apnea in children some years ago. And even from that point, there was a recognition that the deformed face, the narrow jaws, the high palate, the retrognathic mandible were of predictive value for obstructive sleep apnea. And when we take a look at children that keep their mouths closed and are able to breathe through their noses, that generally their nasopharyngeal airway is twice as big as those who hang their mouths open and breathe through their nose, or their mouth or nose and mouth. But those who have that mouth hanging open with the tongue hanging low, away from the palate, allowing the palate to collapse, they're going to likely have smaller airway volumes. This is a very significant finding. So the question is, if I put you at the bottom of a 6-foot pool and gave you a choice of breathing apparatus, I'm sure you would pick the garden hose over the drinking straw or the cocktail straw. And if I gave you a choice between a hose that was made of metal as opposed to one that was plastic or even paper, you'd take the one that was least collapsible. And this analogy holds true because now with cone beam imaging and CAT scans and so forth, we can take a pretty good look at just what kind of airway a person is walking around with. And believe me, there are plenty of people walking around with cocktail straws as readily as there are those with garden hoses. So if we're linking up the size of the airway to the growth of the jaws and the ability to sleep through the night, you start to see a picture of what we're looking at. So the way I'm going to draw this picture between crooked teeth and low sleep quality, is by considering a sequence of events that leads from one to another. I know in the title of my talk, I talked about this concept of ARODS, airway-related oral dysfunctions. And I'm not going to go through this list in specific tonight, but I'd like you to look down them and notice that each of these areas has a link to the airway. And frankly, these are things that many of us in dentistry, not only in orthodontics, but in prosthodontics and dental sleep medicine, in TMJ, TMD and facial pain issues, in oral surgery issues. These are things that we have been struggling with for years and thinking that there was really no answer to. So, but when you put them under this umbrella of airway-related oral dysfunctions, they all start to have some kind of meaning in view of the whole. But rather than go over them one at a time, I'm going to create this connection from crooked teeth on up, and we'll touch on on several of those airway-related oral dysfunctions. So we start off with the modern lifestyle, as I mentioned before, the chronic non-communicable diseases. You can imagine that when you're suffering from any of those problems, that it's difficult to get a good night's sleep, that the discomfort that some of these chronic problems bring on themselves is reason enough not to get a good night's sleep. The modern lifestyle has brought on these environmental stressors, and this is just really a list of some of the most commonly recognized ones. The fact that we have artificial light and we've changed day into night and night into day. Our circadian rhythms seem to be out of whack. The fact that we're eating grass and petroleum is something new to the human experience. We didn't start eating grains until about 10,000 years ago when we became an agricultural society, and we haven't really been eating petroleum until we started making artificial foods, fertilizers, pesticides, and preservatives. The chronic, the autonomic overload of our pituitary, hypothalamic, adrenal axis. This is the fight or flight we were talking about. You know, when we had to run away from the saber-toothed tiger, well, when we were safe, we knew we could rest. It seems that when we have to run away from a screaming wife, bad traffic, we get into the mad boss, the mortgage payment that's due, stress after stress. It seems to be almost unrelenting, even as we think our lives are so convenient and so much better. We're learning a lot about how the human skull, which is this incredible 3D jigsaw puzzle, has to coordinate with growth, over the time from birth until teeth come in, and strains and stresses on the cranial structures can be very influential. Even the way we stand and sit, the fact that we don't move a lot, we're in chairs, we're hunched over our smartphones and laptops all day long and so forth. These have an influence on our skeletal structure and the way the muscles have to hold them up. There are lots of metabolic challenges that we face as well, and for instance, the inability of our body to recognize many of the foods that we've been eating mean that the body has to either fight against some of these elements that it doesn't recognize, or it literally has to detoxify them. So there are plenty of digestive and chronic inflammatory issues that surround our body's struggle with dealing with a environment that it's not familiar with. This particular issue of hyperventilation, hypocapnia is very interesting to me, and I think plays directly into the sleep piece, in that many people, and especially kids, we can demonstrate this over and over, walk around hyperventilating. That is, they're over-breathing, both by rate and by volume, And especially if their mouths are hanging open, there's a significant difference in the exchange of oxygen and carbon dioxide by volume. Much like when you leave a bottle of soda open overnight and lose all the carbon dioxide, kids that go to bed at night and have their mouths hanging open probably blow off more carbon dioxide than they should. That becomes a chronic condition and changes the way we've been looking at sleep. Most sleep physicians look at hypercapnia as the problem. We think chronic hypocapnia is what's leading to problems because of poor oxygenation. That's not oxygenation of the blood, mind you. It's the ability of oxygen to jump off of the hemoglobin and into the tissues. That's defined by the Bohr effect, which we've known about for 100 years. And it also affects smooth muscle tone. So many kids that are having trouble, say, with bedwetting and so forth, with asthma, which is where this particular philosophy got its first introduction, and other organ problems that are related to the smooth muscle spasm become very relevant. What we're learning is that it's almost as bad to overbreathe as it is to overeat, something that very few people consider. Nasopharyngeal obstruction is really important, and also very relevant to this discussion, because when the tonsils are swollen and clogging the throat, as you see on the left, or when frequent upper respiratory infections or allergies or inflammation, occur, it makes it all the harder to breathe when you're sleeping, of course. This open mouth posture issue is the one that I was first introduced to this whole concept with, because this is really what's affecting the teeth. But there are other issues as well. The air passing in and out of the mouth dries the lips. It desiccates the lips. It desiccates the gingiva around the front teeth. It makes the mouth dry. Kids are, waking up with dry mouths, or maybe having to get up to get a drink all the time, mostly because of this air passing in and out of the mouth. And worse, it irritates the lymph tissue. The nose is really supposed to be the filter for air. It's supposed to prepare the air for breathing. And the tonsils and adenoids are supposed to be the last line of defense for nasally breathed air. With the mouth open, they become the first line of defense and are all the more irritated. The scaffolding issue of the tongue was amply illustrated by a researcher who plugged up the noses of young monkeys and watched their faces distort, where the only place they could breathe through was their mouth. And we really see the same in our young monkeys too, because their faces are literally changing before their eyes, our eyes. You can see the venous pooling, the dark circles under the eyes, the narrow nose, the flaccid lips, the tongue hanging out between the teeth, the long, narrow face. These are all signs of an open mouth posture with muscular tone that is just unexercised. The fact that we are eating soft food that doesn't require much chewing is not really helping us at all. And so we wind up with this bi-maxillary dysplasia. And so the palates become narrow, teeth come in the best they can. They're literally floating into place. I certainly don't believe that there's any genetic control over the way a tooth comes in the sense that it knows to come in crooked. This means, and the anthropologists are bearing us out, that crooked teeth really are not a genetic problem. You don't get it from your parents. Now you may get what had your parents also mouth breathing, or of course the shape of our faces does mimic our parents. There's no doubt about it. But for teeth to have to drift in a jaw that's much too small is like trying to put 5 kids in the back seat of your car. It just can't. It's just not going to happen. People used to think, and sometimes they still do. In fact, one father said this to me today about his daughter. Oh, she's got too many teeth. Well, it's really not that at all. It's that the container that's supposed to hold the teeth is underdeveloped and just not providing enough room for the teeth. And so you get crooked teeth and crowded teeth and all the things that go with it, the interferences where they rub on each other during function, or even when they rub on each other during non-functional movements like clenching and grinding that lead to strain and stress on the jaws and pain in the muscles and headaches and the TMJ thing. So that's that in a sense is my connectedness. That's where I'm going to look at sleep quality. Now let's take a look at why the testing for sleep quality becomes important. And that is this. When I finally learned about what sleep-disordered breathing was and obstructive sleep apnea and so forth, I learned that in the adult, the first line of defense, the gold standard, if you will, is CPAP. I also understand that CPAP was never really meant to be a treatment, but it has become so, in a big industry at that. If that doesn't work, then using an appliance to position the mandible forward is the second line, and many of the dentists that are here tonight are very familiar with that, of course. Well, if that doesn't work, then we resort to Roto-Rooter, cleaning out the tissues of the throat and so forth. If that doesn't work, probably the one treatment that really does work is surgery to bring both jaws forward in the face. It may seem a little extreme to do that, but it's probably better than the tracheostomy, which could, really does give 100% relief from obstructive sleep apnea. But if we connect the dots backward and look at adults that have narrow jaws and faces and real dysfunction, that is open mouth posture with the tongue hanging down, and start looking for those habits and where they started and why they're here, we all of a sudden have a better place to start, and that is with children before these problems ever happen. So it kind of brings up a bigger picture for orthodontics, in that we're not going to look at crooked teeth as being the problem we have to solve. In fact, the crooked teeth are the canary in the coal mine. They're just a symptom of some other imbalance. And the slide shows where those imbalances are. And these are the things we need to start paying attention to. Early feeding and nutrition, the allergies, the upper respiratory tract infections and so forth, the way we sit and stand, the way we breathe. How we breathe during the day is probably more important than how we breathe at night. It probably is not really sleep-disordered breathing, but more breathing-disordered sleep. And paying attention to that during the day, I think, is going to show a lot of help for people that are having trouble breathing at night. Same with soft tissue dysfunctions. Many times we can get somebody to hold their tongue up on their mouth, keep their lips closed, breathe through the nose, stand up straight, breathe less, and you can get a better night's sleep just by doing that. And there's certainly a number of studies that show that that can be done. So what are the strategies for airway orthodontics? Of course, you need good diagnosis. That's what we're here to talk about tonight. We want to do prevention. For me now, prevention of this problem is probably the most important thing that I can do for a young child. If I'm not involved in dental sleep medicine, I am involved in preventive dental sleep medicine. Of course, a lot of times we get to see children, the damage is already done, and there's lots to talk about there. But establishing good habits really becomes as important to the teeth as establishing good habits of nutrition and exercise are to your heart. So when do you start this kind of treatment? Well, you start it as soon as you discover a problem. This has nothing to do with braces. This has when do we find out what the habits are? Where are the problems starting for a child? So we know that tonsillectomy and adenectomy is the first line of defense for pediatric sleep apnea, but frankly, that's not all that great an outcome, because there are plenty of people that plenty of kids that don't really find relief from that. And to my opinion, it's because we take out the tonsils, but we never get the mouths closed and the breathing correct. But be that as it may, a lot of these kids are winding up on CPAP. And, to me, it's really a sad thing when you see a 2-year-old having to live on a tube at night and thinking that that's got to be for the rest of their lives. So if our current focus is on the narrow airway, the way we breathe and the volume of breathing is really just as important. So the non-surgical therapies that we have are trying to get the jaw back as wide as it's supposed to be, get the, not only wide, but get the front teeth forward in the face where they're supposed to be. So that's particularly handled well by a technique called BioBlock orthotropics, something that's been around for a long time and is just being started to be looked at as a direct direct technique to ameliorate sleep apnea and obstructive problems in both infants and children. We have to look at getting the nose clear and clean and helping it to stay that way and develop well so that a child can breathe through their nose the rest of their lives. We've got to teach good function of the tongue, both rest posture and swallowing and functional movements. And we have to teach kids how to breathe properly. So in my opinion, this way of looking orthodontic stands poised to aid in the front line of defense of pediatrics sleep disorders. So just to review, these are some of the good habits that we have to establish in children. And my practice has been increasingly involved and evolving to handle these things. And when I handle these things, very often the teeth come in straight. And there's a whole lot less of orthodontics to be done later on. But this brings us to tonight's topic, and I can go through this pretty quickly because the SleepImage monitor has become a godsend to me in the sense that it is something that I can use, even as an orthodontist, even somebody who's not really into dental sleep medicine. I can't read a PSG. I don't, really don't have a grasp on HSTs and all that kind of stuff. But we see how important it is. Here's Christian Guilleminault again, who in 1976 said monitoring children it can be very important because it show not only the sleep patterns but also respiration and cardiac rhythm during sleep. So this is already quite a bit of time before Robert Thomas started his studies, but Dr. Thomas really put it all together by creating the algorithm that allows us to easily monitor just how a child is sleeping. So you've seen this. I don't really have to go over it. I'm going to breeze through these: the high-frequency coupling, low-frequency coupling, and really how easy it is to read just by taking the ratio between the stable sleep and the unstable sleep. You get you get a number that's easily understandable not only to you as the practitioner but to the parent as well. High number, good sleep; low number, bad sleep. It's almost as simple as that. So this is Kelly didn't show this, but this is the way the kit comes. Basically, it comes in this really nice pack that includes the monitor, the lead. They supply all of the disposables, the stickers that hold the thing on. They give you the USB cable that you plug into the computer. You hand this whole package to the patient one night. They drop it off the next day. You plug it into the computer, and within a couple minutes, you have the full report. Sometimes they'll sit there and wait for you to upload it, and you have the immediate feedback from what happened that night. So it's good. The one thing I do now, though, is I always ask them, did you have a good night's sleep the way you think you normally sleep? And did the monitor stay on okay? Because sometimes, especially the little kids, they may knock it off if they wrestle around too much in their sleep. And I just learned about this last year. It's only been about a year that I've done it, and Pat McBride introduced this to me at the AAPMD meeting last year in Chicago, and I immediately picked up on it. I thought it was a great idea because it gave me an easy handle on sleep that I just did not have at all. I've done 82 cases so far, but actually I've not really done befores and afters. Perhaps I should have made an effort to do that, but orthodontics being what it is, you know, cases take a long time, and I haven't really been doing longitudinal data yet, so I don't even have that to show you. But here's the things that I use it for. Number one, I want to look for measurable clues to dysfunction, and it's dysfunctions of all sorts. You know, I measure tongue posture, I measure breathing, we measure carbon dioxide out of the lungs, we measure posture, you know, off of plumb, and here I have a metric for sleep. I'm trying to detect disruptive sleep patterns. I just want to know if things are there, and there are some other things that I have to use as well. I'll talk about in a sec. I want to listen for snoring. I want to listen for heavy breathing. And I use it as a sleep screening tool for people, you know, for me to send the kids to people who know what they're doing with regards to sleep medicine and PSG. So if nothing else, it lets me know when I'm out of my league. Perhaps this next one is the most important of all, and that is it illustrates to the parents the importance of sleep and the importance of my talking about sleep for the kids, and why, you know, I try to connect the dots for them as well. So it's one thing to say, well, how's your child sleeping, and did they get a good night's sleep? But it's quite another to be able to demonstrate to the parents that there is an issue with your child's sleep that we need to look at because it's affecting his growth of his face and teeth and so forth. And then it will help, and hopefully maybe you'll invite me back in a year to show the treatment effects in significant cases. Of course, this modality is not complete in and of itself, and there are other things that have to be used. We are doing, in our medical history, we're concentrating on sleep a lot more than we ever did. And we have specific sleep questionnaires that are relevant. The one we use has been a vetted a study from University of Michigan that asks about you know, sleep quality. We ask the parents, we ask the siblings, you know, because a lot of times the siblings will know more about the kids snoring than the parents do, since they go to bed before the kids. We do ask the parents to stalk their kids, though. Take their iPhone into the bedroom, take some pictures. I want to see if the mouth is open. I want to see the posture. I want to see if the head is tilted back to open the airway. I want to see if the butt is up in the air, or even take videos so we can hear how they're breathing. And speaking of iPhone, there's all these little apps that you can load that'll listen to you sleep and record sounds and restlessness that can be equally helpful. So we put all this stuff together. All right, so I'll just show a couple of cases. I know we're at the end of our time, so I'm just going to go through this really quick. It's just, you know, the typical bi-maxillary retrusion, narrow arches, crowded teeth. Look at the profile. You see the upper jaw back and the lower jaw back. This is, you know, after 2 years of myofunctional orthodontics, that is, getting the tongue on the palate. There's no braces here yet. We're getting the tongue on the palate. We're trying to get him to breathe through his nose. Still, he's quite retrognathic. So I'm wondering, you know, are we doing enough for this boy? And we give him the sleep image to take home, and sure enough, you know, his sleep is is really not where we want it to be. So that, I suffer from, frankly, every year I do things better than I did the year before. And so I look back on many of these cases and wish I had that time back again. I probably would have done more expansion for him. So this is the kind of thing we have to look at. Here's another one that I've been dealing with.
So we can get to some questions too.
Okay. All right. So a 1.62 for a kid who holds his head forward and his jaw back. He's showing a little bit of central phenomenon. Another young girl with a 1.09 with mandibular retrusion, head forward. I mean, I could show these cases all day long. Now, sometimes you see things you're a little surprised about, and this girl has that same pattern. She sleeps okay, so maybe I don't worry quite as much about her. Well, and you're going to see all kinds of variations. This kid's jaws look okay. He's not sleeping well. So, but here's just these are the advantages. It's easy to administer. The kids are not scared by it like they would be with a PSG. The reports are available immediately. I can read it, so you can read it. It's not expensive, so it's easy to add into the armamentarium. And the company is terrific with support. You get to talk to Kelly Olson whenever you need help. So thank you very much. You feel free to write me questions. I'm happy to talk about my experience with it. Just jot down my my information there. Okay, I can hand this back over.
I've got it.
Okay,
and I appreciate it. Thank you very much, Barry. Great perspective, and I like the little twist that we have. What is it? Breathing disordered sleep, as opposed to sleep disordered breathing. That's really something to think about, because we're awake more often than we're asleep, and
it changes the paradigm.
It really does. So I've got just a couple time for two questions, and then any others that were asked, the presenters will be happy to answer and respond to those offline. And of course, either of you can chime in on this. Real quickly, how accurate is SleepImage compared to other available sleep devices? I think that's been addressed largely in the presentation, but if you care to either of you take that one.
I can take that one. Can you hear me okay, Danny?
Yes, ma'am, we can.
All right, good. So the basic premise behind or of cardiopulmonary coupling is the coupling of heart rate variability and respiration, as we talked about. And so research, the literature is chock full of information on those two parameters. But they've shown that that these two parameters will be sort of in an asynchronized state or desynchronized if the patient has poor sleep, and will always be in sync if the patient is sleeping well. So the literature has already sort of laid that path out there, but also in addition to that, the SleepImage device, or the recorder itself, the CPC algorithm, has been validated by Harvard University. Dr. Robert Thomas and his team at Harvard University, specifically Beth Israel Deaconess Medical Center. So there are a number of peer-reviewed publications that are out there and available. And I would encourage people to, listening tonight, to go to the SleepImage website, our website, and have a look at those publications. So it talks about sensitivity and specificity, and in particular with cardiopulmonary coupling. But we know that subjective measures are very poor. With some of the, and Dr. Raphael mentioned that many times people don't even know how poorly they're sleeping because they don't know what good sleep is. And so hanging our hats on those subjective tests, the literature tells us that they're just not, they are not in correlation with sleep. So there has to be other, there has to be other ways to measure sleep quality, and we know CPC is a validated way to do that.
Very good, and certainly more robust than the traditional AHI measure. And is SleepImage covered by insurance?
I'll take that one too. Not to be a bully here, but I'll take that question too. It's not.
I'm certainly.
That's right. It's not currently reimbursed by insurance, but as it does not meet the CMS parameters of a diagnostic device. However, what we're finding is patients are seeing the value in being assessed for sleep issues before having to pay for more of an invasive diagnostic test. And they want to see how they're benefiting from treatment. And so they're paying anywhere from $50 to $100 depending on the patient base and, of course, where they're located. And if it's paired with an oximeter, for example, it is possible to bill for an overnight oximetry, but again, that depends on the insurance company.
I see. And at that price point, I think that really any patient can easily be convinced as to the value proposition.
Correct.
Promises. Well, that's really
correct.
all we have. That's really all we have time for in terms of questions. But I really want to thank you both, Drs. Olson and Raphael, for a terrific presentation on an important and relevant topic. And I also want to acknowledge SleepImage for the very attractive offer that they've agreed to extend to attendees. You can see this on your screen. We will be sending a follow-up email not only so that you can receive your CE credit for this evening's course, but also to consider if you want to take advantage of this offer. And please be sure to mark your calendars for Wednesday, April 2nd at 7 p.m. Central Time, 1 hour later than usual, when we will hear from Dr. Stephen Abrams, inventor of the Canary system, who will discuss caries detection and how caries detection devices actually work, because understanding the technology helps you make the right purchasing decisions. In the meantime, this is Danny Bobrow, thanking you for your commitment to practice perfection. Goodbye, everybody.
Good night, everybody.